इजीली लोगे।
That's the occasion we are. They are all delegations from Afghan Pediatric Association and Afghan. So we are strengthening the newborn care facilities in Afghanistan. So now you have so many witnesses, ma'am. You have so many witnesses.
ठंड तो नहीं लग रही है आपको? एक ही साइड में why don't you people in the back come on these seats? Last 3 or 4 rows, you people can come in the front rows here and there. Will somebody give a suggestion or begin?
Check, 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 check. आ रहा है? Check, 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 check.
नहीं अभी रहने दो। जा सकते हैं। खुला होगा सेंटर? सेंटर खुला होगा? You have to stand over this. You won't be seen otherwise. Are we ready? Huh? Good afternoon. This is the case discussion from Kalawati Children Hospital, New Delhi. I welcome all the viewers for this, and this is a very commonly diagnosed condition, and we will discuss the management issues during this presentation. So, Dr. Chaitra would be presenting the case, and then we will proceed with the discussion. Dr. Chaitra, go ahead.
Thank you, sir. Good evening, all of you. I'm here to present this following case. Here is a male child, 17-year-old male child, Kannu, resident of Delhi. Informant is elder sister, who is reliable. He predominantly came with complaints of increasing pallor since 8 months of age. Child was apparently well till 8 months of age when the parents noticed increasing pallor along with excessive irritability and crying. He was then taken to a private hospital initially, where they were told that the child required blood transfusion, and hence for the blood transfusion was referred to Kalawati Children Hospital. He received his first blood transfusion here at 8.5 months of age, and certain blood investigations were done. 15 days later, the parents were told that the child had some blood disorder called thalassemia, which would require lifelong blood transfusion, and the child was called for regular visits to the hospital, and since then he is under regular visit to Kalawati Children Hospital. Treatment history and the course of the illness. Beginning from 9 months of age, the child has been receiving blood transfusion from this institute only at an interval of 3 to 4 weeks once, with no significant increase in any transfusion requirement, and till date he is requiring transfusion every 3 weeks once. And he has always been transfused under the thalassemia center in Kalawati Children Hospital only. Following blood transfusion, there were no history of any febrile reaction or history of jaundice or any major side effect noticed by the parents any time. Along with the blood transfusion, the child was also started on some oral medication that was told to be Kelfer at around 2.5 to 3 years of age, which he was taking 3 times daily, and he's still on that drug. He also gives history of intake of folic acid tablets since then, along with that tablet. As told to the parents, in view of increasing serum ferritin, that is told by the sister, one more drug was started since past 2 years, which is being taken daily once. Since the time the child is being followed here, the child is being regularly monitored at every visit, as told by the sister, with certain blood investigations and certain monitoring according to their knowledge. The details of monitoring will be discussed subsequently after the examination. Only one point will be discussed here. During the regular monitoring, the parents were told that the child had inadequate gain in the height and delayed maturation, and hence was referred to a special OPD in the same institute. There certain blood investigations were done, and the child was told that the child has delay in gaining height and delayed maturation, and was started on some injections which was given monthly in the gluteal region for 12 months every monthly. It was started in November 2013 and he received up to October 2014. The details of further investigations and monitoring will be discussed subsequently after the examination. There was no history of any delay in transfusion anytime. There was no history of any increase in the transfusion requirement. There was no history of fever. There was no history of any massive abdominal distension. No history of bleeding from any side any time. There was no history of jaundice or history of right-sided abdominal pain. No history of bone pain, joint pain, or lower back pain. There is no history of palpitation, difficulty in breathing, swelling of the legs, swelling around the eyes. There is no history of nausea, vomiting following the drug ingestion. And there is no history of any difficulty in hearing, or there is no disturbance of vision. Family history: the child is third in birth order, and according to sister, the parents had also undergone some blood investigations earlier. However, the sibling has never undergone any testing. Birth history: it remained uneventful. It was a normal delivery, and the postnatal event was uneventful, and till 8 months of age the child was all right. Developmental history: the child had attained all developmental milestones according to the age, and he was going to school till 4 years back, and from past 4 years he's not been going to school because of personal reasons, which I'll be covering in the socio-economic history. The immunization history: the child was immunized according to the national immunization schedule till 5 years of age under this hospital only. And they also give history of receiving hepatitis B vaccination 5 years once from past 10 years. However, there is no history of receiving any costly injections anytime. Nutritional history: the child is deficient in calorie intake, is consuming only 70% of the expected calories with adequate protein intake. Socioeconomic history: the father has expired. The only earning member of the family is the brother-in-law, who stays with the child and the mother and the sister. And according to modified Kuppeswamy classification, the child belongs to lower middle class. And to mention about the personal history here, the child has some personal issues. Since 2010, the child has left going to the school. Earlier he was good in studies according to the sister, and due to the death of the father and the subsequent financial reasons, according to sister, the child doesn't go to school anymore. On examination, he's a 17-year-old boy. He's comfortably sitting, oriented to time, place, and person. His vitals are pulse rate is 96 per minute.
Ask him to stand up here and face the camera.
Pulse rate is 96 per minute, adequate volume with all peripheral pulses palpable, and respiratory rate is 18 per minute with no respiratory distress. CFT is less than 3 seconds. Blood pressure is 104 by 64 mm, measured in the right upper arm, which is between the 50th and 90th centile. The temperature is however afebrile. And anthropometry. Weight of the child is 28.75 kg, which is 66% of the expected. Height is 144 centimeters, which is less than third centile, 81% of the expected, and which is less than -3 standard deviation according to WHO growth chart. The BMI is 14.8 per meter square, which is less than third centile and less than -3 SD, with severe thinness. And on
according to the anthropometry, how would you describe the nutritional status of the child?
the child is undernourished, definitely, because there is stunting, there's severe stunting with underweight and the severe thinness.
Okay. So thinness and stunting.
Stunting.
Right.
Would like to ask this one thing. Is it proportionate short stature or disproportionate short stature?
It's a proportionate short stature. Upper segment and lower segment ratio is around 1 to 1.1 is the ratio of the upper segment and lower segment. On general physical examination, some pallor is present. There's no signs of icterus, clubbing, cyanosis, edema, or lymphadenopathy. There is no change in discoloration of the skin, and there is no obvious change in the facial features suggesting of any hemolytic phases. Otherwise, the rest of the physical examination remains normal. And the SMR staging, sexual maturity scoring, was done, which suggested SMR stage 2 with a pubic hair stage of 2 to 3, a testicular volume of 8 to 10 ml.
What are the findings in the abdominal examination?
So abdominal examination, so palpation, only positive findings.
Yeah.
Sir, on palpation, it's a soft, non-tender abdomen. Liver is palpable 3 centimeters below the right costal margin in the mid-clavicular line, which is firm in consistency. It is a smooth surface with sharp margin and non-tender. Liver span is 13 centimeters with dullness starting in the fifth intercostal space. And spleen is also palpable 3 centimeters along its long axis, which is firm in consistency and with splenic notch palpable. Rest of the examination system, including cardiovascular system, is normal. Bone, joint, and central nervous system is normal. Even the skeletal system was examined, where bone, joints were normal and with no restriction of movements or no swelling or any tenderness in the joint.
All right. So, can you summarize from the history, this child who was 8 months old and what all is happening to him? And what are the current problems that he has?
He came to us, he is now currently 17-year-old. He came to us at the age of 8 months old for blood transfusion, where he was diagnosed as thalassemia, and from then he is under follow-up for repeated blood transfusion. And after 2 to 3 years of starting blood transfusion, he was simultaneously started on chelator therapy, initially receiving only 1 chelator, and now from past 2 years, because of the increasing serum ferritin levels on combination chelator therapy since past 2 years, and with no increase in transfusion requirement any time during the past 16-17 years, with however on routine monitoring where the short stature was picked up and subsequently worked up for that, and the child has been treated for the delayed, and it was told with the short stature the child had delayed puberty and was treated for the same.
All right. So, one thing is that the diagnosis is a thalassemic and he is regularly getting transfused. The other is that with one chelator, the ferritin was not under control and he has required another chelator in addition to ferritin. sorry, the deferry prone calfer. The third thing you mentioned was that he is short statured and he also had delayed puberty. So, in such situations, how do you define what is, when do you really start acting on the delayed maturation of, delayed sexual maturation of the child?
Sir, when there's a complete lack of secondary sexual characteristics by age of 14 years in boys, it is defined that we have to start working up for delayed puberty and short stature, which could have many reasons. The short stature could have many reasons. In this case, it is one reason could be anemia, which is however was controlled. The iron overload, which causes the endocrine complications because of the iron overload in the pituitary gonadotropic cells, which can cause the hypogonadism, hypogonadotropic hypogonadism, and the chelator toxicity. However, no chelator toxicity was suspected in this child. And the nutritional deficiency, the child was on continuous supplements of calcium, folic acid, and initially the diet was also good. From past 4 years, because of financial constraint, everything has come down. Then, sir, even on the chronic liver disease, any associated infections, where the child has been screened also for transfusion transmitted infection, which has been negative after yearly screening.
Okay, so one thing you said was that if he was inadequately transfused, that might be responsible for some growth delay, right? The short stature might be related to that. Other general problem not related specifically to thalassemia could be nutritional factors because of the social issues, like he is not belonging to a very good, economic background. So that could be one. The other could be several endocrinopathies could occur because of the iron overload. So you mentioned pituitary, and particularly you were mentioning about the hypogonadotrophic hypogonadism. But are there other endocrine involvement which could lead to short stature in thalassemics?
Yes, sir. Hypothyroidism, hypoparathyroidism, and even osteoporosis and osteopenia, which is.
So if you look at the say thalassemics from the very beginning, like this child had been with us since beginning. So do we have a growth record of this, how he was growing earlier and what is the, can we have a look at that? Even growth hormone deficiency can occur in thalassemics. So all endocrine involvement could lead to the short stature. In this child, probably the endocrine workup which was done, delayed puberty was considered as one cause, and that is being addressed by giving the treatment for it. So, yeah, just describe this growth chart in this child.
This is a growth chart. This was the Indian version. According to Agarwal chart, this was plotted. From the beginning, the child had a short stature. The height was recorded from around 4 years of age, which was like less than third centile. But he was following the curve, though he remained below third centile throughout the monitoring. And at this stage there was intervention was done at this stage where testosterone injections were given for delayed puberty because the LH, FSH and the basal testosterone levels were low, and we can however see a growth spurt at this point of time. We could not compare with the mid-parental height because the father was never available to us. But this was a case of clear cut of short stature without even the mid-parental height because of the background disease. We always thought the disease and the endocrine complications were responsible for the short stature.
One thing very significant noticeable here is that if you look at the first dot that you have on the chart, which is at what age? 2 years?
So
4
4
years?
years.
4 years, right. So at 4 years, he is below third centile, and the curve is going further away from the lowest curve that you have, right? So there was further growth failure, and this is actually very typical in thalassemia. They might be growing quite well till about 7-8 years. Mostly beyond 10 years of age you get the growth failure. Even in those, this is basically in those who are adequately transfused. So, and after that a large gap is there, and when the intervention has started, before that the gap from the what is this lowest line is third centile line or 3SD line. What is this on the growth curve?
Fifth centile.
Huh?
Fifth centile.
Fifth centile. So it's quite far from the fifth centile, and now it is catching up, or rather it's reaching slightly higher on the graph. Okay. So this is after the intervention there is definitely an improvement in the height gain is there.
Show the serum ferritin.
Yeah, you can simultaneously show what other monitoring has been done.
This was the annual transfusion rate just of the past 5 years. There was never a significant increase or a significant fluctuation. It has remained between 170 to 190 ml per kg per year, constant for the past 5 years. And the trend of serum
Actually,
ferritin.
just go back to the previous slide. So actually the graph has been put in such a way that the variation looks too much, and maybe the transfusion requirement appears to be decreasing. It's just that 185 and 170, the gradation had been made in such a way that it's showing a wide range. But more or less, so when do you say that transfusion requirement has increased?
Sir,
Theoretically?
When it depends upon the even the hematocrit of the blood we are giving. Otherwise, usually
on your annual transfusion requirement that you are monitoring, when do you say, when you get alarmed? At what annual requirement you get alarmed?
More than 200 to 220, more than 220 ml per kg per year.
Even more than 250 particularly, and so actually one needs to calculate the pure red cell requirement. For that you have a formula that negates the hematocrit of the blood that you are giving. So 225 to 250, beyond that, or other criteria is that if you have splenectomized children, that used to be criteria earlier. Like there were some children who were splenectomized, so their requirement vis-a-vis the patient's requirement you could compare. If it is drastically different, then you start working for the cause of increased transfusion requirement. So would anybody from the audience like to tell, you would like to tell what could be the causes of increased transfusion requirement in a thalassemic?
Causes could be immune mediated reactions, that is the hemolytic reactions which can occur due to multiple transfusions in alloimmunization which is occurring. Second can be increase in due to increase in the size of the spleen. There can be hemolysis which is occurring in the spleen, and transfusion mediated infections can also cause increase in transfusion. Yes, sir. Sir, any infections which are not related per se to thalassemia, like dengue, malaria, they can also cause an increase in transfusion rate.
Okay, brings in another point, like there could be a short-term increase in the transfusion requirement, say over 2-3 months following an infection like dengue or malaria. The transfusion requirement could be there, increased transfusion requirement could be there, but then it would settle down. But if it is a chronic increase in the transfusion requirement, then you would like to look at these causes. Like you said, splenomegaly, but splenomegaly, unless there is hypersplenism which sets in, that could be one. And amongst the transfusion requirement, increased transfusion requirement due to transfusion transmitted infections, HIV is one which could lead to increased transfusion requirement. Then any other would you like to add? Any other cause?
Parvovirus infection.
All right, so there could be, again, this would be a short-term increase because of a plastic crisis, because of parvoviral infection.
Associated vitamin B12 or folate deficiency. Because
Particularly if the patient is inadequately transfused, there could be increased folate requirement, and if there is dietary deficiency, so there could be folate deficiency, and that would lead to increased transfusion requirement. All right, and alumination you have already addressed. Anything else? You were mentioning about the hematocrit of the blood that you are transfusing. So when you are working up such a patient, and particularly when you have looked at these common causes, or rather even before that, one should try and find out if there is a change in the practices of the blood bank. You know, like they were packing the packed cell more, and suddenly the things have changed, the technicians got changed or something. So the hematocrit of the packed cell, PRBC that you transfuse, that has gone down from, say, something like 70 to 58 or 59 or 60. So that would be a drastic change. So that would increase the transfusion requirement. You want to ask?
Quality of blood also, if we get a old, not fresh blood,
Yeah.
that will also increase the transfusion requirement.
So when you are working up such a patient, all these factors need to be taken into account, and one has to, like if particularly if you are thinking of splenectomy in the child, these all causes should be excluded.
So we have monitored the serum ferritin levels also. Just of the serum ferritin is usually monitored 3 monthly once. Here, as we can see, 2011 and 2012 there was a significant increase in serum ferritin, for which combination chelator therapy was decided to add, and hence Desirox was added at this stage along with Deferiprone.
So the ferritin is monitored for iron overload, status of the iron overload. Now, could you tell what other tests are there for monitoring the, or is it the best test available to us for monitoring the iron overload?
Though it's not the best test, it's the most feasible test that is available for us. Because though it's not a true reflector, and though there can be variation, fluctuations in the levels of serum ferritin in because it's acute phase reactant, still this remains a choice because of the easy feasibility and because it's non-expensive. However, the best modality of reflector of serum ferritin could be to detect iron overload in liver or in heart, the cardiac overload. There's MRI T2 star done, which is now recommended. This basically is a reflector of the iron status. It quantifies the amount of iron in the cardiac or the cardiac myocytes or the hepatocytes. That is available. Though liver iron concentration through liver biopsy is the gold standard, it is not a feasible option, and it is not. It's not routinely, or it's not done.
So the iron overload and the status of iron deposition in various organs, that becomes even more important when the patient is started on chelators. Why? Like initially maybe it's just that ferritin could be good enough, right? But even if you do LIC in a child say young child, it would be reflecting the liver and total body iron. But over the years, if the patient is receiving iron chelator, even liver iron will not reflect the cardiac iron too well, depending upon what chelator is being used. I have given you a hint. So, what is the reason? When I said chelator, on chelator, the serum ferritin is not the only thing one should monitor. Anybody? Yes.
Like desperoxime are large molecular chelators, so they will chelate the
That is common.
blood iron more effectively rather than the tissue iron. And the small molecule like desirox, they are so the iron chelators. Some are like large molecule like the desperoxime. They chelate the blood iron more effectively than the tissue iron, which is more effectively chelated by the small molecule like desirox. So if we are giving deferoxamine, then the blood iron, like the ferritin, will be low, but the tissue iron concentration will be high. And the
Okay.
And
Anybody else would like to add anything to this? Partly you have explained the things. Chitra, now you want to add up something to this?
It's not a true reflector because in the liver also there's a hepatocyte. Iron is loaded in hepatocytes and the reticuloendothelial, the macrophagic cells. So
Actually, the ability of what Abhishek pointed out was that the ability of various chelators to chelate iron from different tissues is different. I mean, depending upon which tissue you are taking into account. Like desferoxamine is a very good iron chelator from liver. And you know that with desferoxamine in Western countries, the survival had improved. But still the cause of death, when the death came, the maximum mortality was due to cardiac iron overload. So, if you look at the iron chelation from heart muscles, myocardium, the deferiprone is better. Because again, what Abhishek said, a small molecule. Deferiprone is a small molecule compared to desferoxamine. So, if you have a patient who is on deferiprone, his cardiac status, iron status would be much better compared to a patient who is on desferoxamine. Deferasirox or desirox leads to iron chelation from heart as well as liver, both adequately. Deferiprone is not a very good chelator from the liver. Desirox is, but not deferiprone. Deferiprone is very good for the heart. So, at some stage, people talked of using a combination of deferiprone and desferoxamine. So, we were monitoring ferritin, and has he undergone any, since he is now 17 years, has he undergone any evaluation of heart or liver iron by T2 this thing, MRI imaging?
In 2013, he has undergone one MRI T2 star imaging, where both the cardiac iron status and the liver iron status were normal. It was within the normal. It didn't suggest any features of overload, iron overload. This is
okay, but ferritin was persistently high at 4,000.
4,000. So this was from 2010 only. The previous records say it was between 1,000 to 2,000. This was the time I've specially mentioned because a combination therapy was added at this point of time, 2012. Okay. So this has been.
Okay. Yeah.
Chitra, I want to ask you one question. Suppose you are monitoring ferritins, then what other conditions it can get? What you will keep in mind when you are taking ferritin as a marker? In what other condition it can be altered? So that we should keep in mind before increasing the dose of any drug.
It is an acute phase reactant, so any acute infectious conditions or any acute inflammatory conditions, if the child is symptomatic in that way, preferably serum ferritin should be avoided at that visit, and once the acute illness subsides, and only then the ferritin should be
any other condition in which it should not be given much importance if it is increased? Any other condition leading to very high ferritin levels other than inflammation or infection? Anybody else can tell me?
Liver damage
Hepatitis.
because of the
Hepatitis can also
hepatolysis.
cause erratically high values of ferritin.
Okay.
This was the pre-transfusion HP levels, which was always maintained past between 9 to 10.5.
So what do you mean by adequate transfusion? What are the strategy that we are using with this transfusion regime?
Adequate transfusion where we maintain the HB pre-transfusion HB, which is monitored at every visit between 9 to 10.5. It should remain between 9 to 10.5.
Diet is important.
It is important because of the growth, the physical activities, and the complications, everything, and even the extramedullary hematopoiesis. Everything is suppressed if the HB is maintained at the adequate level.
Yeah, so from the very beginning, once you are putting a child with transfusion dependent thalassemia on regular transfusion regimen, the pre-transfusion hemoglobin of 9 to 10.5, this is will allow a proper growth of the child, and it will keep the patient's own hematopoiesis suppressed. So bone marrow expansion and extramedullary hematopoiesis does not occur, right? So it would keep the splenomegaly and hepatomegaly under check, and other manifestations of extramedullary hematopoiesis, they will not occur. And that is the reason he does not have any facial features which in maybe say a decade earlier or 2 decades earlier, we were having some patients who had facial features quite like what textbooks had described. So, Chatra, in a child, say from very beginning, at 8 months he was started, do you just follow the hemoglobin to say that it is adequately transfused, or you look at certain other things clinically?
So clinically, we look into the, as mentioned, the growth monitoring is done regularly, and importantly, the size of the liver and spleen is also monitored.
That's right.
And any evidence of even the bone pain because of the osteoporosis or osteopenia, which is like mainly attributed to the extra bone marrow expansion and cortical thinning. That
I think growth of the child, particularly in the initial years, initial 2 to 3 years, that reflects the adequacy of transfusion the best. Maybe in certain cases you might get that even at this pre-transfusion hemoglobin, the growth is, or the some features of extramedullary hematopoiesis are coming up. In fact, in our center we have a couple of cases in whom with pre-transfusion of this level of 9.9 to 10.5, he still has the skull changes. So we are trying to maintain a higher hemoglobin in that child. Maybe his hematopoiesis is not adequately suppressed. He is younger than this, he is about 10 years old. And I think we recently had taken a decision that his pre-transfusion hemoglobin should be kept high. So, very rightly pointed out, splenomegaly and hepatomegaly, that should be seen. And are there any other markers of, other than hemoglobin, lab markers of adequacy of transfusion? Any idea? And if somebody wants to have very stringent control on this, the adequacy of transfusion has to be checked. What will happen if the patient's hematopoiesis is not completely suppressed? What will be there in the peripheral blood?
fetal nucleated
Fetal
RBC.
hemoglobin will not reflect much because fetal hemoglobin, after many transfusions, fetal hemoglobin is not going to give you too much of a idea. Huh?
Leukoerythroblastic picture.
Thrombocytosis is not something, no, we don't rely that on. You mean anemia leading to thrombocytosis? No, not really.
Leukoerythroblastic picture.
Well, reticount
and
is one. Otherwise, one looks at the nucleated red cell. There should not be many. I mean, just 1 or 2, not more than that. Nucleated red cell should not be there in the peripheral blood. And have you heard of the transferrin receptors? Could that have a role? Anyone who has any idea about what transferrin receptors are? Because Abhishek? Transfusion receptors are actually some glycoprotein receptors. You want to say something, Surya? No? They reflect the hematopoiesis. If there is active hematopoiesis, the transfusion receptor would increase on the cell, the erythroblast or the precursor cells, and when they are increased up to a certain extent, they start coming up in circulation. So what we measure is circulating transferrin receptors. And obviously, if the hematopoiesis is kept under control, the transferrin receptors would be at a lower level. If it is high, which means the erythropoiesis is not adequately suppressed. Okay, but again, this is a research tool we have done in one of the thesis, but otherwise it's not something we routinely keep doing. It's an expensive test also. So for adequacy, you have these things, and then adequately transfused child in his adolescence should have a good growth spurt, right? So growth is important for adequacy of transfusion in the initial 3-4 years, and later on at the time of the growth spurt that you have in adolescent or pre-adolescent age group. And then you said you will monitor the iron overload by ferritin and other tests as we discussed. Can you tell at what age one should start looking at the cardiac and
Usually,
liver iron?
we start after 10 years of age. We monitor the cardiac and even before the echo. There are changes in the echo, and there's a compromise in ejection fraction. The changes are picked up on the MRI T2 star. But still, echo should be done routinely, yearly once, and even MRI T2 star of both the cardiac and liver imaging should be done yearly once. Along with it, we look for even the long-term complications. Should be certain monitoring of complications should be started after 10 years. Like the thyroid profile because of the hypothyroidism as a complication, the fasting blood sugar, and the to look for even the OGTT levels for the impaired glucose tolerance or over diabetes. It should be done yearly once, or symptomatic, or as I indicated, after 10 years of age. And even a DEXA scan should be done after 10 years to look for any changes in the bone mass, the bone mineral density, because they are susceptible to osteoporosis.
What is supertransfusion and hypertransfusion?
Supertransfusion where we hypertransfusion where we try to maintain hemoglobin levels above 10 gram, and super is about 12 gram per deciliter we try to maintain. It is preferred in certain conditions where there is an underlying cardiac disorder, or the extramedullary hematopoiesis is not suppressed by the moderate transfusion regimen. It is then indicated to.
And why not beyond 14 gram percent? I mean 12 to.
Because of thrombotic complications of the hyperviscosity and the thrombotic complications.
Stasis will lead to further decrease in oxygenation and thrombotic events.
She has commented about osteoporosis, osteopenia. So, can somebody tell me what are the causes of osteopenia, osteoporosis in these thalassemia patients? Pravjot, can you please tell me?
Nutritional deficiencies can be one cause of osteopenia and osteoporosis. And second is secondary endocrine abnormalities. When the endocrine abnormalities are seen in these patients, they can always lead to a decrease in calcium and vitamin D metabolism, which can lead to secondary osteopenia. Also, in case the child is not adequately transfused, in that case there can be extramedullary hematopoiesis and a decrease in the cortical When cortical weakening of bones, which can cause osteopenia.
Any other cause?
Ma'am, even in case of a chronic chelation therapy, there can be a side effects of, ma'am, they have got certain skeletal abnormalities, and osteopenic side effects can be seen with chelation therapy also.
If Puneet wants to add something to this. Okay.
Can chelator therapy lead to zinc deficiency?
Anything else you would like to add? What?
So the other causes, these patients are very prone to get osteopenia, osteoporosis syndrome. So the causes can be, like as she has correctly said, that can be nutritional deficiency. Otherwise, if they are inadequately transfused, that can be chronic anemia, can also be one of the cause. Then chelation toxicity, then various endocrinal complications like hypothyroidism, hypoparathyroidism, and hypogonadotrophic hypogonadism. Then there can be other factors like PTH and vitamin D excess problems. So there can be vitamin D deficiency, which these patients are very prone to. And another cause can be various genetic factors like VDR gene mutation, as well as COL1 gene mutation, which can also predispose them, some of the patients, to very high risk of osteopenia, osteoporosis. So we should be adequately monitoring these patients for these complications also.
Yeah, one osteopenia, osteoporosis actually has come in a big way in these patients over the last, I think, a decade or maybe 15 years or so. The reason being that since the survival is improving, these complications are getting more attention. So this is not a complication which you will usually see in 10, 12-year-old child. And in fact, if a 10, 12-year-old child has bone pains or such symptoms, then the other causes like vitamin D deficiency or nutritional calcium deficiency or zinc problem, or those are more important. But the thalassemia related or the which is endocrine complication related osteopenia, osteoporosis, that sets in mostly, say, at this age, around later part of second decade or third decade. And this is the time when DEXA scan should be done. And I mean, if one goes by the monitoring that these patients require, like she mentioned, getting a DEXA at the age of 10 years. In a child who is asymptomatic, I would probably not get an DEXA so early. And if the symptoms are there, then of course one has to investigate. But otherwise, say 15 years or so, one should start. Because everything costs. Now, one thing more I wanted to point out, that compared to the osteoporosis that we see in elderly, this is more common in males. That is one, and that is because of the testosterone deficiency that has a role in the bone mineralization. So the boys or young men with thalassemia are more commonly affected by osteopenia, osteoporosis syndrome than the girls. So you showed us the monitoring of these patients. All right. While we are on monitoring, what other monitoring is required in these patients? Day to day, weekly, monthly, or not weekly, monthly, or 6 monthly or yearly?
We have to monitor for both organ dysfunction and the chelator toxicity. For the chelator toxicity, it depends on which drug the child is on, which chelator he is on. Because the major side effect of deferriprone is neutropenia and agranulocytosis. So absolute neutrophil count should be monitored monthly. And Desirox has a complication of renal impairment and liver impairment. So at a monthly renal function test, kidney function test, and liver function test should be monitored to look for any elevation or impairment in the LFTs or KFTs. And even we should routinely monitor for transfusion transmitted infections. It is mainly for monitoring. We have hepatitis B, hepatitis C, and HIV, which is monitored yearly. Every year it should be monitored for the transmitted.
So transfusion transmitted infection, that is another area, and of course the chelator toxicity. for which the hemogram and LFTs and KFTs every month, and then auditory and
even the
evaluation, right?
hearing evaluation.
Chatra, you mentioned about hepatitis B vaccination. What about A? Is it important?
Hepatitis A is important in these children because they are prone for transfusion transmitted infection, hepatitis B, hepatitis C, and also iron overload can cause liver disease, chronic liver disease. So in such cases, hepatitis A vaccination is recommended because even hepatitis A can have a fulminant course in such children. So hepatitis vaccination should always be advised and should be ensured that it is given.
Yeah, there are several reasons why hepatic dysfunction could occur in these patients, and once the hepatic dysfunction is there in these patients, the hepatitis A could be more severe than rest. So these are the cases where hepatitis A vaccination should be done. It should be preferred. These situations.
Sir, just would like to know, our child is a thalassemia with short stature. We have talked about osteoporosis. There are no questions over here also. In how many percentage of these children, in spite of good transfusion and chelation, we have short stature? One. Secondly, out of these, how many of these approximately have disproportionate short statures? And in Indian experience or our experience, what are the major prominent causes of short stature, sir?
Would you like to answer these questions?
Indian context in
Percentage of short stature first, in spite of all the treatment. Do we all of them have short stature, or they can have a normal stature with adequate treatment, adequate transfusion and adequate chelation?
They have, but it is reported around 50 to 60% can have hypogonadism as a complication, endocrine complication of around 50 to 60%. Delayed puberty being the major cause for short stature. So delayed puberty has been reported up to 50 to 60% as a complication.
Actually, if we look at the data from our center, we analyzed a few years back, and certainly with the better treatment, I meant that the transfusion availability of the blood has improved over the last decade, and of course the chelator has become available only for last 2 decades. Earlier than that, the patients were not receiving iron chelation. Calfer came in 1994. So even with Calfer, whatever ferritin control was there, iron overload control was there, over the last 6-7 years there is further improvement since the Desirox was used, and even now our patients over 10 years of age, if I remember correctly, some 50% of them have short stature, which was earlier in 65 to 70%. So, and the major cause is the delayed puberty. So that is there. We have looked at the endocrine status of these patients also. The hypothyroidism is not very common, and growth hormone deficiency is seen in about 10-15%. But major is the hypogonadism that is leading to this. Disproportionate, when we say disproportionate, is usually not seen in thalassemia. Maybe if there is hypothyroidism, maybe they would have disproportionate. And another cause of disproportionate where the upper segment is short typically is described in children who from very early age were receiving desferoxamine, because that is, it's a very peculiar side effect that is described, is that the vertebral body's height that was reduced and sitting height of the individual is less. So the upper segment would be low, and the compared to lower segment, that would be disproportionate short stature.
Thank you, sir.
Any other question from there?
No, sir.
No.
We do not
Okay.
have any more questions right now.
All right. So this is a grown-up boy with thalassemia. One very basic question, like you were there when this child came at 8 months. How would you have investigated and picked up the diagnosis? What you would see in the peripheral blood? Let us complete the discussion by going over these aspects.
Complete blood count is done where there is an hemoglobin will be less and MCV is less, MCH will be reduced, and a peripheral smear picture would show microcytic hypochromic anemia with anisopoikilocytosis with nucleated RBCs and basophilic stippling and there will be the red cell distribution would usually be normal and
Red cell distribution width would be increased because it's always people get confused when we talk of peripheral blood picture, thalassemia major and thalassemia trait. So what you are saying, RDW is not increase in thalassemia, that is about beta thalassemia trait. Okay. Yeah.
And we
be
can
careful.
even have a leukoerythroblastic picture
That's
on
right.
peripheral
Yeah.
smear.
Yeah.
With
Retic count?
So retic count is increased.
How much?
So 5 to 10%.
5 to 10%. Okay. Huh? Usually it is less than 8%. All right. So if you have a child with say hereditary spherocytosis or some acquired hemolytic anemia, the retic count would be very high at times, but in thalassemia, no. Could you tell why in thalassemia they are saying that retic count is not higher than say 8% or something like that? Anyone who can explain the reason?
The erythropoiesis ineffective.
Yeah, ineffective erythropoiesis is the reason, because the retic count is not going to increase if the erythropoiesis is not proper. Okay. So if you have a child where even if they develop the Coombs positive increased hemolysis, even then the retic count does not increase because there is a defect in the bone marrow. Okay. So if you have a child in whom you are working up for hemolytic anemia, you have retic of 15-18%. No, it's not likely to be thalassemia. Okay.
Can somebody
Then
tell
yeah,
sorry.
yeah. Go ahead.
Can somebody tell me what is leukoerythroblastic picture, and in what other condition it can be there other than thalassemias?
You said the leukoerythroplastic picture. What does that mean?
There are nucleated RBCs. There's an increase in the nucleated RBC seen on the peripheral smear, and there is a shift of neutrophils towards the left. There is increase in the number of metamyelocytes, and myelocyte can be seen on the peripheral smear, along with thrombocytosis. Can be seen. It can be seen any infiltrative disorders, any infiltrative conditions of the bone marrow, like leukemia or even a Hodgkin's or a non-Hodgkin's lymphoma infiltrating into the bone marrow, myelofibrosis conditions of.
So leukoerythroblastic picture means that you have precursors of both the red cell as well as leukocytes in the peripheral blood, whether there is associated leukocytosis or not. Incidentally, what is the status of TLC in a thalassaemic patient at the time of say acute initial presentation?
Should be increased.
It is usually high or why it
Falsely
is
high because they're counted as.
falsely high. Okay, even if you say that corrected TLC, your pathology lab mostly gives a corrected TLC, because why it is falsely high? Yeah, because of currently you are doing that on electronic cell counter, and the normoblasts are taken as say lymphocytes, or they are counted as that, and the TLC is increased. So if you do a DLC, correct it, even then there is true leukocytosis, right? So that is related to hypoxia. Hypoxia leads to stimulus of the bone marrow as a whole, not selectively to only erythroid series. Okay, so there is some degree of leukocytosis. In iron deficiency anemia also you get some degree of leukocytosis, same is here. Okay, so next investigation for diagnosing thalassemia?
HPLC, LC. where there's a different
HPLC or short of that, electrophoresis. The HPLC is
electrophoresis.
something which is there in big cities and maybe some moderate size cities also, but in smaller cities that facility is not there. So one might like to do only HB electrophoresis. Okay. So what do you see in that? What do you get?
Increasing the hemoglobin, fetal hemoglobin, more than 95%, 90 to 95%, or it could be variable. If the child has never received blood transfusion, then it could be very high HbF levels, 95 to 100%.
So do you mean to say that the higher the fetal hemoglobin, more is the severity of the disease?
It is a presentation, age of presentation, or not receiving blood transfusion earlier, that it may be a reflector of that than the severe.
You are yourself giving me a question that how would you diagnose if the child has received transfusion and you are getting just a, say 5-10% HbF. So what one should do in such a situation? Say the child was anemic, somebody before referring to your hospital gave a transfusion, right? When you received the child, he has already received a transfusion, say about 1 week back or something. So how do you go about diagnosing such a case?
We can parents, the electrophoresis of parents can be done to look for the whether if they are thalassemia trait, or if there is an option for genetic mutation analysis, should be going out to look for.
If we see that both parents are trait, we will assume that this child is thalassemia major.
Based on the clinical history also.
Okay, yeah, clinical history is there, microcytic hypochromic anemia is there. So, do we assume that this is thalassemia major if he has presented that early? Or something else you can do to get a do HPLC again, or at something like that? Huh?
Wait, and we should.
Yeah, how long you want to you need to wait?
3 months.
Yeah, it has to be quite long. I mean, you don't let the hemoglobin fall that much that he has cardiorespiratory symptoms. So otherwise, you give a good gap of about 6 to 8 weeks and then repeat an HPLC. But at times, this waiting also doesn't yield the results. Still, you have a HbF of 10, 12, which doesn't give you a correct diagnosis of beta thalassemia, which could be transfusion dependent. So in that case, what do you do?
In that case, mutation studies.
Mutation studies, right. So the mutation studies would be like, I mean, you need to look at the center where these are done. I mean, we don't have this facility here, but you have to convince the family that this is the diagnosis for the lifetime. So it's better to spend some money even if they are required to. Otherwise, try to send at such a place where it is minimal expensive. Okay. So that's the way you need to diagnose such cases. All right. So once you have diagnosed a child and say presenting at this age, you would feel that it is thalassemia major. Okay. Now, what you are going to tell the family about the disease, about the management of the child?
Counseling and explanation should be given at every stage, at the point of diagnosis, at the time of first transfusion, or even at the time of starting chelator therapy. At the time of diagnosis, we should reveal the nature of the disease and the genetic background responsible for the disease, and options for future options to prevent any similar illness in the future siblings, of option of antenatal screening and subsequent therapies. Subsequently, in the antenatal screening, the options in the antenatal screening and the mode of termination if there is some evidence of thalassemia major or homozygous.
Point of view, what you will tell the family? Tell exactly what you will tell. You have said broadly this would be the philosophy of explaining the things to the family. So, what are the treatments option available? Huh?
Uh,
Yeah.
in our setup, if the we should always give them options for treatment, whether they would require a lifelong blood transfusion, or would they would like to go for a hematopoietic stem cell transplantation. If they have a matched donor sibling, and if they can afford, they should be given an option for that, or we should be telling if that is not the, and the same thing, the consequences of stem cell transplantation should always be explained about the failure, or the failure of that modality of treatment, or would they opt for the lifelong transfusion and the chelation and the iron.
Right. I mean, there are two forms of therapy. Bone marrow transplant is curative. As you said, it is expensive. They need to have money, and most importantly, a matched sibling donor. Allogenic transplant with matched sibling donor is the best. And if they have that available, like if the child's brother, sister, they are matched, HLA matched, and regarding the cost of treatment, as far as transplant is concerned, it's not that if they are poor, the transplantation is not a possibility. Like if you are diagnosed, say, at 10 months of age, they could plan for transplantation, say, at a later date, and they would want to know from where they can get funds. Like there are several agencies from where the funds could be arranged, like there is Prime Minister Relief Fund, from where a donation of 3 lakhs can be received, like or a grant of 3 lakhs is received, maximum they can get. Several like Arogya Nidhi and MLA Relief Fund and MP Relief Fund. So wherever they can go and find out, some relief might come their way. And then meanwhile, say a child would be, at what age the transplantation is done? Do you have any idea? Say you have diagnosed in infancy, at what age the transplantation is usually performed? Anyone? This is something we don't talk much while we are looking our patients in thalassemia center, but you would like to tell at what age they do? Yeah. Minimum they say that the recipient should be 2 years age, and so the donor. Right? If you have a child of about 3 years, 2 years at diagnosis, and younger say is few months, you will have to wait that the donor also becomes 2 years of age. Okay, so they will have time. I mean, one could wait. Earlier the better, but 2 years the time most of the transplantation centers would feel comfortable doing, though now people are trying in younger children also. And if, say, this child had a elder sib which he has, one could have thought of advising that stage, but then planning for the funds and all that, that might take time. So the transfusion therapy anyway has to be given till, even if they decide for the transplant or otherwise, the transfusion and chelation program has to be, followed for some time at least. Yes. One is that you need to take out a good amount of marrow, and the safety of anesthesia and all those things, because you need to anesthetize the donor for say 30 to 45 minutes minimum, and you need to collect the marrow to up to a amount, like whatever is the figure for stem cells that you need. So you can't do it in a very small. So transplantation possibility should always be told, whether the family is poor or well-to-do. And then you were mentioning about the genetic counseling at the time of diagnosis. That is very important. In fact, in situations where you are waiting for the effect of previous transfusion to go away and reinvestigating. Even in doubtful situations, because if the child is young, maybe they are planning for another child, so they should be told that they should wait till the result of this investigations are available to us. So once for all, we should know that whether the family has someone having thalassemia or not. So in between, you mentioned about the mutation studies. Are you aware of some mutations which are common in India?
So, certain mutations which are common and come across the reports are like inverse IVS 15 I5 and IVS I1 and this frame shift mutation in one,
not IVS 1,
1 and 5.
Yeah.
And frame shift mutations of 41, 42 and 8, 9 mutations and 619 base pair deletion. These are the common mutations seen in Indian context.
So generally when we send for the testing, what they do is that they test for 5 common mutations. That would give them the answer in almost 85 to 90% instances. So 1 in 10 patient would be such that the 5 common mutations are negative, right? And at least maybe in one of the parents. And then they ask for more fund, more money to be given, because 5 common mutations they would have charged in the beginning itself, whatever labs are performing. And then they look for the rarer mutations. So you rightly said that these are the 4 or 5 common mutations in Indian patients. And this also varies, like there are some mutations which are more common in Punjab, there are some which are there more in Gujarat and Maharashtra, like and there are some which have more severe course, and there are some mutations which are having less severe course. Okay. Any other question? All right. Once we are talking of severity of the illness, what are the determinants of severity of thalassemia? In a thalassemic or even thalassemia major, do they have same severity or they have different severity?
Severity is again, there can be different severities based on the adequacy of transfusion. Again, if they are well controlled, thalassemia patients who are under.
No, that is you are talking the clinical, that they are well managed or not. I mean, the important thing is that what are the determinants which are influencing the need of transfusion requirement.
Yeah.
Say somebody would need every 3 weeks, another would be requiring transfusion every 4.5 weeks.
Yeah.
Somebody might be requiring every 2.5 weeks. So what are the
They are
determinants?
like homozygous, the mode of whether they are like.
Well, within the homozygous, let us talk of within homozygous. The heterozygotes do not need transfusions. Okay. Beta chains are affected or alpha chains are also affected. How that is going to determine? Can you take the mic?
So in case the alpha chains are also being produced less, in that case the ducts formation will be less and the hemolysis as such the total hemolysis will be less. In case a beta thalassemia major is associated with alpha also.
Okay, so like the unbalanced alpha chains, they get precipitated and the cell damage and hemolysis, right? So if the alpha chains are also suppressed, and the imbalanced alpha chains would be in a lower quantity and the hemolysis or ineffective erythropoiesis would be less. Okay, that is one.
Is there co-inheritance of any other, if there's HB sickle cell disease along with thalassemia, or a HBE disease with beta thalassemia, or
right.
HB HB lipo, any other variants, hemoglobinopathy variants associated with beta thalassemia?
All right. So that is also there, like sickle beta and E beta. They are traditionally described as having milder course compared to beta thalassemia homozygous. Double heterozygotes with E, or actually thalassemia mutation in a E will increase the severity of E, but E, this association moderates the severity of beta thalassemia. Okay, so does the sickle. Any other? What about the? You might have heard about beta gene mutations, beta 0, beta plus, and all that. What is that? Huh?
Beta.
Huh?
Beta plus is
What is that? Beta 0, beta plus?
Beta plus is some amount of chain, beta chain is produced,
Yeah.
and beta 0 is where absolutely no beta chain is
Beta
produced.
0 is when okay.
Low.
So and then there is another beta. Some people write it as beta 0 plus and plus plus. Some would write beta 0, beta plus and query. So very this all like beta 0 would be complete suppression of beta chain production, and if somebody is now, will that affect
severe clinical
yeah,
course
so
and
beta 0 homozygous, beta 0 and plus double heterozygote, that will make a difference. Okay, so you have genetic influences also on they describe it as primary modifiers and secondary modifiers and tertiary modifiers.
Even the polymorphism in the HbF modulator gene can also lead to decrease the severity of thalassemia blood transfusion requirement.
In fact, what is the usually described HbF level in a child who is, say, transfusion dependent thalassemia? What is the HbF level in them?
92 to 95%.
No, actually 90
no,
is
more
not
than 50% usually.
Generally they say more
most
than 50%, but say 50 to 70, 75, 80%. But if it is 90%, one should be alarmed that there is something more than just thalassemia. So as Dr. Nupur was pointing out that very high fetal hemoglobin, that could be other mutation like hereditary persistence of fetal hemoglobin or some such thing.
One more question I want to ask from the audience. Like suppose a patient come to us with a clinical history. Of repeated transfusion, typical of transfusion dependent, with HPLC, which is also not very conclusive because it is post transfusion. And we got the parents' HPLC done, and we found that one of the parent is clearly thaltrate. In another parent, we found that PS is microcytic hypochromic, but HPLC is within normal limit. So can we exclude that this patient is not thalassemia major? So, in that parent, what thing that we should look for, or we can exclude that my parent is not thaltrate.
The patient should not be iron deficient. We should repeat the HPLC after ensuring that the patient is not iron deficient.
Okay. So iron deficiencies are also excluded. There is no iron deficiency. Still, the HbA2 level is within normal limit. Then what should we
alpha
suspect?
mutations, associated alpha mutation.
Alpha gene mutation, the HPLC would be normal. Any silent carrier, what is that? We all are silent when we are diagnosing the carrier status. There are some mutations in which the HbA2 is not elevated, right? This one, capside. What is that? Yeah.
The most common Indian mutation is capside.
Yeah. So in that the HbA2 is not elevated. So this is something tricky. Like if you are counseling and somebody in the antenatal period, they say that your electrophoresis is normal and the one of the partner has trait. So if they ask 100%, we can be assured that the child is not going to be thalassaemic. There you need to counsel, particularly if it is a Punjabi family, that they should undergo this mutation, okay, to be doubly sure. So, okay, now coming back to this child, we discussed lot of aspects related to him and related to the diagnosis and the treatment. Now, this family now wants what better can be done to this child, or what is the prognosis? As there might always be questions about survival, their well-being, and life as an adult.
The issues with this child was the growth and the delayed puberty. So, addressing that first, it can be told that there is still scope for the increase in the height because of the growth spurt has just started occurring, and up to 21 years of age, it is seen that there is a chances of the increase in height. And about the puberty, though the puberty can be achieved, counseling should be done, and appropriate counseling should be done in terms of the fertility of the patient, because that can be compromised. And about the life expectancy, sir, that is again dependent on the various aspects.
So, like this child, you say that his ferritin is now coming down, he's maintaining a good hemoglobin. Other than short stature, there are not many issues. The sexual maturation is catching up now. So, MRI T2 star done 2 years back were normal, but I am sure if you did we repeat this? No, we don't have the repeat. Okay, so there would be some degree of cardiac involvement, cardiac iron overload, and maybe now it will regress with further continuation of both chelators. So, what are the chances that he would grow into a good adult or not? As you said, till early 20s, their height could continue to increase because still the epiphyseal fusion has not occurred, right? So they thalassemics keep on gaining in height till like it's not a normal child who stops gaining in height after 18 years of age, but they would increase, and he might have be very close to the cutoff for short stature, so or maybe he can cross. So that is one, and for fertility, as you said, one need to give a guarded prognosis, and particularly this is a boy, so the related to function and the reproduction, both sexual function as well as as well as reproduction, one has to give a guarded prognosis, right? We will like to say to this family, one would like to say that we will like to observe him more with the treatment before we give any such thing. But what is currently the survival in India? Any idea? Are they surviving into yes, Amli? Yeah.
35 to 40 years.
Now, actually, over the last, this change has occurred only recently. Now the patients are into their 30s and some of them even in 40s, and many patients are now married, they are having their children, right? So, they are close to normal individuals, except that they need transfusion and iron chelation. Okay. Anybody who would like to ask anything else regarding thalassemia or its treatment, diagnosis? Okay, this child is receiving both oral chelators, and let me tell you that this is not something which is say has approval of FDA, or these two drugs have some combined toxicities. There are very few reports of these two drugs being used, published reports, and the largest one is on 16 patients. It has been found to be safe. This combination has not led to increased toxicity of one or the other, and well tolerated and effective. Currently, rather over the last couple of years, 3-4 centers in India, they have used it in large number of patients, and my personal information is that everybody is happy with this combination. Very good ferritin fall, and there is some data with them, the other centers, that they have shown T2 star values also improving. Okay, so probably a more careful monitoring is required, and since the overlapping toxicities are there, and otherwise one can use this combination. But again, I mean, this should be done in a proper manner rather than just everybody is writing both the drugs. Anyone who knows about the prognosis of transplant in thalassemia? Any prognostic classification, something like that? Have you read about this? No? Okay. So actually, there are 3 well-defined risk factors, although now people are talking about the utility of these risk factors, because initially the transplants were started, although the first thalassemia transplant was done in US, but initial large series came from Italy. Lucarelli was the fellow who did a large number of thalassemia transplant, and they had identified 3 factors which would indicate the outcome of transplant in thalassemia, and in which one was that the patient should be adequately chelated, second, presence of hepatomegaly, and third, presence of hepatic fibrosis. Okay, so then they had, if no factor was present, I mean, if the patient was adequately chelated, had no liver enlargement and hepatic fibrosis, this would have no risk factors, and this would be class 1. Presence of 1 factor would mean class 2, and presence of 2 or 3 factors would mean class 3. So currently, those patients who are undergoing transplant, since the initial management, transfusion chelation management has improved, the patients are better chelated compared to what it used to be earlier, and the prognostic significance of these factors is being questioned now in several of the new papers which are coming up. The another new development in thalassemia transplant is that people are talking of unrelated donor transplant, matched unrelated, the MUDs, or the haploidentical. But haploidentical means one of the parent could be a donor, and there is no question of then availability. I mean, any of the parents could give haploidentical marrow, but then there are still few cases who have undergone this, and these are more expensive than a allogenic matched sibling donor transplant. So they cannot be recommended right and left. But since we are talking regarding thalassemia, and somebody might ask you that we have heard about haploidentical, they might come with questions like cord blood. A lot of patients keep asking about cord blood. Cord blood transplant again is something which is for a young thalassemic, maybe this might be useful, but then cord of a unrelated donor right? From cord blood bank, if you have received, that again would be more expensive. It would be like matched unrelated donor. So those are not something very consistent recommendations for thalassemia transplant. Any idea about T2 star values of what values are good, what values are bad? Amli? Huh? More than 20 is bad? Is normal, okay. So higher the value, huh? Huh? Better it is, and lesser than 6 to 8. This is in relation to the heart we are talking, right? So yeah, they are bad. All right. If a patient develops cardiac dysfunction because of iron overload, what you are going to do? Intensive chelation therapy. All right. So what does that mean? Intensive chelation therapy.
So, combination with high dose.
Combination, high dose of what?
Desferoxamine,
Huh?
deferriprone and desferoxamine combination.
Okay.
Therapy.
Yeah, currently they manage with the desferoxamine infusion. When you say desferoxamine high dose infusion, what does that mean? Huh? Usual dose is 20 to 40. If you are going to say 60, and some people have even used up to 100, and it goes on continuously over 24 hours, massive chelation, and with of course deferriprone being used, since that is going to remove the iron faster in such situations. So combination of desferoxamine and deferriprone, right? In relation to that, why it is very effective?
Shuttle and sink and
Shuttling, all right. What is that shuttle and sink?
Sink and shuttle.
Shuttle and sink mechanism. Can you explain that?
So desferrioxamine, because of its larger molecular weight, stays outside, and deferriprone, it is a good cardiac chelator. So more effectively it chelates iron from inside the cells, and this iron being transferred to desferrioxamine, which gets easily removes the plasma iron.
So deferriprone enters the cells, binds to the iron, brings that compound out, releases the iron, goes in again, right? And this iron is now available in extracellular compartment to desferoxamine to remove it through the kidneys. Okay, so that is the shuttle mechanism. And there are how do you combine deferriprone and desferoxamine therapy? When you say combination, what does that mean? Like this child, 4000 ferritin, if you were not using the oral chelator, or the time when oral chelator was not available, how you would have combined desferoxamine and
Desferrioxamine given as a nighttime subcutaneous infusions.
okay, it is given as nighttime subcutaneous infusion. Okay, is it more effective at night, or why it is given at night?
Long time of the
Yeah,
treatment
you
that
need
should
to
be.
give it continuously for 8 to 10 hours, and that's the time when the child would be sleeping. So one could put a subcutaneous needle and give it. So means that is given at night, fine. How often you will give that? How often you will give deferriprone?
A sequential.
Huh? Deferriprone you can continue daily.
Daily.
Hai na?
That is given at the night,
and this you can give, say, if the urgency of fall that is required is much, then you would give slightly more, say 3 days, 4 days, but otherwise you could give it 2 days. And if it is just you are bringing the ferritin down, or the T2 star values are just borderline, so one could combine that way, 2 to 3 days in a week, and the oral chelator is continued continuously. Okay.
We have a question from Dr. Anita Mehta from Gorakhpur. Are there any contraindications for bone marrow transplantation?
Contraindications for bone marrow transplant. Actually, we are not doing transplant here, so I am not deeply into it. But to my knowledge, there is no contraindication. Nupur, would you like to add? I don't think there is a contraindication to doing a transplant. The only thing is that transplant has its own problems. It's not that the transplant is done and everything is fine. Like there could be long-term complications like long-term GVHD, etc. And maybe if you tell that there is a high chance that the child would lose the fertility after the transplant. So that could be a deterrent for some families. In fact, in one of my patients, they said इससे तो फिर चिलेशन ट्रांसफ्यूजन चिलेशन से ही आप कह रहे हो चांस है कि वो फर्टिलिटी होगी, एंड वो वंश चलाने के लिए भी चाहिए ना कोई. So in that situation, but to my mind, the transplant probably there is no strict contraindication. But I would say that I have a limited information on this. Yeah.
Sir, we have another question from Dr. Ramesh, who is from Andhra Pradesh. He's asking, is there any role of hydroxyurea in management of thalassemia?
Would you like to answer? Role of hydroxyurea?
In probably non-transfusion dependent thalassemia, it has a role because especially there are even certain polymorphisms where in sickle cell anemia and non-transfusion HBE beta thalassemia, where they are non-transfusion dependent, hydroxyurea acts by different mechanisms which can help in management.
Yeah, that's right. Like in sickle, it's a treatment known. In relation to thalassemia, as Chitra has rightly pointed, that in non-transfusion dependent thalassemia, hydroxyurea has a role, definite role. Not consistent, but in some patients it is of real benefit. And not only by increasing HbF, there are several other reasons why it works. In thalassemia major, there are reports of some decrease in transfusion requirement in some patients. In across the country, there are some reports, but it's not consistently something recommended. And as she is mentioning, there are certain mutations that if you identify those, in a big way, people used to say that XMN1 polymorphism. If a patient of thalassemia is homozygous for XMN1 polymorphism, then he is likely to respond to hydroxyurea. But our own experience, we have seen that even such patients did not, though not in a very large number. And finally, it is believed that even XMN1 polymorphism is more, a better determinant in certain other types of mutations than that we have in India. So hydroxyurea in thalassemia major, we do not use regularly.
We do not have more question. I have one question.
Yeah.
After how many transfusion or at what level of serum ferritin is skin hyperpigmentation evident?
The exact value of serum ferritin increasing more than
Okay, before that, let us come to a very basic question. Like you have started the patient, like this child was started at 9 months. When you will do the first ferritin?
After 10 to 12 transfusions.
Yeah. And what ferritin you want that should be maintained? I mean,
less than 1000. Less than 1000.
Yeah. So if it is more than 1000, you start, and when with your consistent use of the drug, it is brought down to Currently, the level of thalassemia major, in thalassemia major, the level of ferritin considered is 700, not 1000. We have gone down further with the level. So, what question Dr. Mukesh has asked that after how many transfusions there would be skin pigmentation obvious. I don't think there could be a consistent answer to that. But if you are not chelating in those times when our patients were not getting chelation after 4 to 5 years of their transfusion therapy, which means roughly 50 transfusion, 40 to 50 transfusion, they would appear to be iron overloaded by just their look. The grayish hue to the skin was there. Question?
We have one more question, sir.
Yeah.
It's from Dr. Elizabeth from Andhra Pradesh. She wants to know, is there what is the difference between the lifespan of a transfusion dependent child with chelation and another child with transfusion dependent without chelation?
It is definitely low with a non-chelator. The iron toxicity is almost evident at the end of first decade. Around 10 to 12 years, the complication starts. The cardiac overload, the cardiac complications, and even the liver complications start. And life expectancy is definitely low. And
there's a large body of data which shows that if you are adequately transfusing, you are making them live into their second decade. If you are adequately transfusing, third decade and beyond. Now the adequacy of transfusion, the chelation is also getting redefined. Like as I said, from 1000 the current recommendations are go down to even 700, and then you maintain at a lower level of the dose. So there is a large body of data, like if the patient were well chelated, this is say I think 10-15-year-old data, their 30 years plus was some 70-75%, but those who were not chelated, just 10% were crossing 20. Yeah, so I mean there is no question that chelation has improved the survival. It has improved, definitely. In spite of chelation, the patients die in their 30s, 40s. That is the problem. So after the first, as we discussed, now a person might, you might be asked, or let me ask you, if a child is getting a ferritin done at 2 years of age or 2.5 years of age, and his ferritin is 1100, which iron oral chelator you are going to start?
Oral.
You are going to start oral only,
2.5.
or you would like to give desferoxamine?
New
Huh?
oral chelator only.
Right.
Deferasirox is.
Deferasirox. Why?
Maybe because of the compliance also, it's to be taken once daily, and the side effects. It is the lefty and caved. Though they have side effect, there is no absolute contraindication. Like in deferriprone, once a child has developed neutropenia or something, it can never be given. It should be always deferred, the drug. But in Desirox, there can be dose modification can be done if there is a adverse effect also. And
okay, I don't think there is a strict recommendation on which chelator to use. But you are very right, the compliance is a big issue. The way you give, particularly in India, we do not have liquid preparation of deferriprone. But we have deferasirox available as dissolvable tablet, and it is taken as dissolved in water. It's not that older child would take swallow the tablet. No, it has to be dissolved in water or some fruit juices. It has to be taken like that. So compliance would be better. The side effects like joint pain, etc., which are problematic in deferriprone, this has a better safety profile. Some patients do have problems of nausea, vomiting, and at times diarrhea. But then in that also, the people say that in a country like India where gastroenteritis is so very common, every child on Desirox developing diarrhea should not be attributed to Desirox. You should re-challenge the patient. But if the problems are there, then of course one can think of using the other. But I would agree with you that the Deferasirox has to be the first chelator to be used. And that is what we are consistently doing now. And we hope that over the years, after long-term use of Deferasirox, the life would be much better than compared to those patients who initially had Deferiprone and now they are switching over to combination or maybe monotherapy with Deferasirox. What are the side effects of Deferasirox?
Renal impairment and
Renal impairment. Okay. What is that? Renal impairment?
It can cause.
How significant is that? Does it require alteration in treatment doses?
It requires alteration treatment. There are based on the GFR.
Is it reversible, irreversible?
It is reversible on dose modification or stopping of the drug. And creatinine clearance, usually they have mentioned 60, less than 60, the drug should be stopped, and it's a contraindication to start the drug also.
Okay.
And liver damage, liver parenchymal damage can also be seen. And acutely.
Liver damage sounds very.
Alteration in the liver function
liver,
test.
Transaminitis.
Transaminitis.
Mostly. Okay. What about the cytopenias? Are they known with this drug or not?
More evident with Deferiprone.
More common with Deferiprone, but cytopenias are known with even Deferasirox less often. And of course, nausea, vomiting, diarrhea, as I said, these are the other side effects. Any other side effect? His age but tall, and he has several endocrinopathies. Part of his cardiac dysfunction was probably related to hypocalcemia. I think hypocalcemia was, calcium level was some 0.8 or something. It was definitely less than 1, 0.8 or 0.9, whatever was the figure. So we gave him intensive chelation. His cardiac status had improved.
Sir, like we have a child who is presenting in CHF in the emergency, should we start him on chelation at that point of time, or should we manage the CHF first and then start him on?
Well, I don't think there could be any first or second thing like the cardiac thalassemia and thalassemia management in the country as a whole. I should say it has improved over the last 2 to 3 decades. Initially, there used to be questions like how much hemoglobin should be maintained and what is the ferritin, how to go about it. Now the questions are different. The families are asking, will this child be a normal adult male or female? Should they marry? Whom they should marry? So there is a real advance in the treatment, but I should also say that in smaller towns the situation is not as good. We still do get cases, all of you might have seen here, inadequately managed cases from neighboring states where the transfusion facilities, leave-aside chelation, they are not as good as in metropolitan cities are. So, but still we should feel that thalassemia has now become a chronic manageable disease. It's not a disease which used to be fatal when, say, the chelation was not available to us. Okay, I think with this I would like to thank the family first. What is his name? Kanu and his sister who have stayed with us for more than 2 hours. Chatra, who presented the case, and my co-consultants here, Dr. Nupur, Dr. Pyali and Dr. Mukesh, and Dr. Kamal was also there. Of course, all in the hall who are there, and everyone who is watching this webinar. Thank you very much.